Today's topic, we are going to do spinal anesthesia. So spinal anesthesia, this involves the injection of local anesthetic into the subarachnoid space, and this one usually produces a reversible loss of sensory and motor function. Kindly note, not only sensory and motor function, but also autonomic function. So it produces an excellent condition for surgeries below the umbilicus. So it is used for, so if below umbilicus, so we'll have procedures that are obstetric, gynecological, urological, lower abdominal and perineal, and lower extremities surgery. So the examples of the surgeries include inguinal hernia repair, hemorrhoidectomy, anal fissure, cesarean section, abdominal and vaginal hysterectomies, transurethral resection of the prostate or the bladder tumor, lower limb surgery that including the orthopedic, vascular, and plastic. So the spinal cord of a human being usually ends at the L1. So L1, whereas for an infant usually ends at L3. This is very important because as you have said that the spinal anesthesia will inject the local anesthetic into the subarachnoid space. So if you have to inject, you'll have to inject below. If for an adult, you'll have to inject below L1 or L2. So that is L3, L4, or L4. So the spinal technique, the preparation, you do monitoring of through non-invasive BP monitoring, heart rate, respiratory rate, pulse oximeters. You also give IV fluid access through running. You give IV fluid access and then you put a running IV fluid. And then you do preparation for general anesthesia, that is airway support if required. And the reason behind this, if you need to change to general anesthesia, then you need to be ready. And this is very important in an emergency session. So next is patient positioning. You can either position the patient in a sitting position or lateral decubitus position. So next is you identify the two first line, and the two first line, this is a line that is drawn that is between the iliac crest. So that line actually corresponds to L4 and L5. And this is important because we have said that the spinal cord usually ends at, an adult spinal cord usually ends at L1. So then you do the spinal anesthesia can be performed either at L3, L4, or L4, L5 interspace. Layers traversed by the spinal needle include skin, we have subcutaneous tissue, and then we have supraspinous ligament, and then we have intraspinous ligament, and then we have ligamentum flavum, as you can see here, and then we have the epidural space, and then we have the dural matter, and then we have arachnoid matter, and then now we have the subdural space. So the complication of spinal anesthesia include, the first one is hypotension, and this is the most common complication due to spinal blockade. As we said before we started, that spinal anesthesia blocks the sensory, the motor, and the sympathetic. The next could be bradycardia, nausea and vomiting, itching, shivering, short-term hearing loss, high spinal or total spinal, urinary retention due to blockade of S2, S3, and S4, postural puncture headache, infection, that is meningitis, epidural abscess, neurological complications such as coda inguina when you injure the spinal cord. You can also have direct needle trauma to the spinal cord. So contraindication of neural axial anesthesia. Neural axial anesthesia usually include epidural spinal anesthesia, and the absolute contraindication of this is patient refusal. So when the patient refuses, that is an absolute contraindication. Infection at the site of injection, coagulopathy or bleeding disorders, uncorrected hypovolemia. As we said, one of the complications is hypotension, increased intracranial pressure, and aortic or mitral stenosis, and local anesthesia allergy. So relative contraindication is, this is the pre-existing neurological deficits, congenital or acquired spinal anomalies, post-traumatic vertebral injuries, and sepsis.